Moving on, we have the next set of chairpersons with us. We have Dr. Milind Desai, MBBS from Goa Medical College, consultant in general internal medicine. And along with him, we have Dr. Amit Kumar De, diabetologist, general physician and geriatrician in Apollo Sugar Clinics, Newtown, Kolkata.
Good morning, everyone. And in this session, we are going to learn from the founders of Diabetes India. And to tell us with the first talk, I invite Dr. Jamal Ahmed Sir from Aligarh. Sir is an MD Medicine, DM Endo, FCCP USA, PhD Med, FRCP UK. He is a former professor of endocrinology and director, Rajiv Gandhi Center for Diabetes and Endocrinology. He's a faculty of medicine, Jawaharlal Nehru Medical College Hospital, Aligarh Muslim University, Aligarh, India. And Sir is going to talk about diabetes care in India, challenges and solutions. Over to you, sir.
Thank you, Chairperson. And I really am very thankful to Bansi, Manoj, the Arvind and entire team of Diabetes India for asking me to be here. Obviously, I am associated from the beginning with this Diabetes India when the conceptual program was presented by Sadikot. We had a meeting in Mumbai. And the thing that I admire for that gentleman was that he was having vision and he was having commitment. These are the two things that we have seen the fate of Diabetes India now, and I hope with continuous effort from each one of you, this conference must go on. So I'll be talking about diabetes care in India, what is challenges and solutions. You are all aware it's a global emergency, with the Southeast Asia being one of the major contributors. Presently, there are about 8 crore people in diabetes, 8 crore people with diabetes in India. 1 in 7 of all adults living with diabetes worldwide, and there are about 60 lakhs deaths annually. So, diabetes, you all know, is the biggest challenge in developing nations, and Asia is the center of global epidemic of diabetes due to rapid economic development, urbanization, and nutrition transition. The major burden of diabetes is now in developing rather than developed countries, and 80% of the people with diabetes live in the low income and middle income countries and comorbidities. There are certain possible reasons for increased prevalence. One, that the increased prevalence can be due to either increased incidence, increased survival duration, or due to combination of both. Increased incidence can be a reason but not the sole one. You all know that with improvement in the healthcare, the duration of survival due to strict diabetes control has improved, and the treatment of complications has also improvement is somehow better now. Obviously this increase in the survival, increase in the incidence or a combination has led to increased prevalence, and is affected by both the incidence and duration of survival. And we know that prevalence we calculate by incidence divided by duration of the disease. Also, there is younger people are affected, particularly in South Asia. We know that the classical description of thin fat Indian concept is there. We are developing diabetes about a decade earlier. We are having coronary artery disease a decade earlier as compared to Western counterpart. This is the status of diabetes control that was, the data was presented by ICMR India study, and across, you know, that different regions of the country, the average diabetes, average A1C always has been between 8 to 9% in both rural as well as urban population. Now, if you see the across just study the urban and rural population, both male and female, and you can see here that A1C was less than 7% in about only 35% people in this study. The blood pressure 140 by 90 on an average about 49%. The total cholesterol less than 200 was achieved in around 70% of the people. The triglyceride around 48%, and LDL cholesterol less than 100 was achieved only in about 36 to 40%. There is a huge disease burden of diabetes. Further, we all know that roughly about 30 to 40% people with type 2 diabetes, they have got chronic kidney disease. There is more than 2.5 to 3-fold increase in the incidence of cardiovascular mortality, increased risk of stroke, and the other things which have recently come up, that about 30 to 40% patients with type 2 diabetes, they have got heart failure, and those who suffer from heart failure, the prevalence of diabetes is further increased by 30 to 40%. Mortality in diabetes, you know that 50% is because of the cardiovascular disease. So these are some of the prevalence of complications that we see in type 2 diabetic patients. This data was presented by Mohan et al. Long time back. And what he said that coronary artery disease occurs about 26% of population, cardiovascular disease 8%, peripheral vascular disease 11%, diabetic retinopathy 20%, neuropathy 34%. These are one data where we just have the retroactive analysis of about 10 years data of those patients who are coming regularly in the university, and we have found that neuropathy was present in about say 15% of people, nephropathy 7.5%, retinopathy 16%, hypertension 25.8%, and coronary artery disease 15.5%. So these are the main challenges which are posed in India about the rising prevalence both in urban and rural areas, the high prevalence of pre-diabetes. There is definitely the role of genetic and environmental risk factors, rising prevalence among young people, high cost of diabetes treatment, the limited healthcare facilities, the low incidence, low disease awareness program. There is always delayed in diagnosis, suboptimal control of diabetes, and rising rate of diabetes complications. So there is a general lack of awareness among type 2 diabetic patients about these complications, whether it is a cardiovascular disease or the cardiovascular risk factors or the cardiovascular events. You all know that grossly there is lack of awareness in these people. And here you can see that this awareness of diabetes in India, that is studied reported a long time back, and they show that the prevalence of diabetes is 9.3%, awareness only 45.8%, unaware of diabetes 54%, taking treatment only 36%, and diabetes under control 15.7%. So the lack of awareness is one of the main reasons, and this is the predominantly, you know that India is an agricultural population. A vast majority of cultivators are small farmers in village. 80% of total population live in the rural areas. There is always shortage of trained personnel. By teaching lay people regarding diabetes, the diabetes is often diagnosed with the onset of vascular complications and potential morbidity from retinal, renal, and arterial disease associated with diabetes. The Chennai, again the Chennai urban rural epidemiological studies showed that nearly 25% of population were unaware of a condition called diabetes, and 40% of the participants felt that prevalence of diabetes was increasing. And again, this is the another data from the Indian Council of Medical Research, and they show that knowledge and awareness about diabetes in India, particularly in rural area, is very poor. This underscores the need for the conducting large-scale diabetes awareness and education program. This is just about chronic complication. Again, that was published long time back from our institute here, and they showed that there is increase in this prevalence of both micro and macrovascular complication, in diabetes because of the increasing duration of diabetes. And this is our again the 10 years retrospective data of about 12,000 people which followed regularly who were attending the institute, and they show that if you talk about on the left side, see the A1C, only 27% people were able to achieve A1C of less than 7% over 10-year period. If I talk about triglyceride, only 41% people were able to achieve triglyceride over long-term period. HDL cholesterol 44%, LDL cholesterol only 45%, and hypertension around 67%. This is the 10 years retrospective data from a tertiary care center where I was working. Now this is the current status of diabetes. Again we analyzed over 1 year data because of development of so many anti-hyperglycemic agents, and what we have seen that over 1 year period only 18% were able to achieve A1C of less than 7%, 7.7 to 9% were able to achieve A1C of between 7 to 9%. And it just after 1 year when the data was analyzed, what we found out over 1 year only 20% were able to achieve A1C of less than 7%, and majority of people were still having A1C between 8.8 to 9%. And this may be because of many reasons, because there is complexity in management. You know that diabetes has got a lot of pathogenic factors. There are more than 12 defects which have been identified. And if you just see the data here about the use of sulfonylureas, the glitazone, saxagliptin, sitagliptin here, and you can see that complexity in management is because of the low adherence, medium adherence, and high adherence that I have already shown. And the fear of hypoglycemia is one of the contributing factors. So in the complexity of management, if you talk about, there are so many factors. One is clinical inertia, polypharmacy, adverse events, caregivers, visual impairment, and difficulty in using insulin injections. And these clinical inertia, you can see that it may be the physician related, it could be patient related, it could be because of the health care system related. And the major problem is access to medical care. You know that diabetes is a chronic condition, it's characterized by degeneration, and there is a progressive development of macro and microvascular complication with ongoing chronic hyperglycemia. And again, this is maybe because of the low socioeconomic group, and there might be a lot of financial problem in these patients, and we don't have any good government programs that can deliver these access to medical care in these people. So the complexity needs in diabetes care, again, of course, there should be physician consideration. One should know what is the, one has to know the understand the prevalence, avoid therapeutic inertia, and basically because the goal of care is to prevent complication and optimize quality of life. And there are so many factors which are responsible in the complexity of diabetes care. So these are some of the patient-related barriers in diabetic management. I am sure all of you know there is a lack of awareness, poor motivation, economic constraint is there is stress, confusion, and immediate benefit is not seen. There is a lack of family support and lack of trust in healthcare providers. And most of the centers, both in the government institution and other places, they don't have any dedicated diabetic educator program. So if you want to have these unmet challenges, you have to address all these factors in totality if we talk about the good diabetes care. So therefore, after knowing some of these problems, let us talk about what is the solution. Solution here, of course, is at the primary care. First is in the public sector, it has to be developed. There should be expand the basket of laboratory investigation for maintaining the continuum of care. You have to have central data collection, performance of the clinical audit, and if possible just to ensure uninterrupted supply of the drugs. The patient-centered care, you lack need of paramedical staff that has to be equipped with, and there should be community outreach program and the peer support. And these clinical inertia, a lot of these factors have been, a lot of these studies have already published, and basically all these studies show that basically we lack the dedicated diabetic educator deliver about the awareness and complication of this disease and how it should be monitored. So I see on studies till now mostly has been the data has been observational and interventional studies are not available. Cohort studies to evaluate the quality of care and assess long-term health care problem, and we have approved the observation research program. And of course, if you want to have this complexity of management, you have to have generation of the data, formulation of the locality available guidelines based on the evidence rather than on expert opinions. You must have the training of healthcare professional and paramedical staff. And this is the simple RSSDIE side therapeutic heal, and that has shown you the hierarchies of the management right from the inner corner to the outer side, and you have to implement based on the patient choice, the patient-centered approach, and the decision has to be shared. And finally, you must be able to know address the use of technology, which is going to play an important role. Everybody has got a mobile, labs and all, and these technologies are really helpful nowadays. You talk about the improvement in HbA1c. Previously we talk about the control of A1C, means that you have addressed the diabetes need, but you know that A1C is not the goal only. You have to have the fasting and postprandial blood glucose. You have to maintain HbA1c. You have to see the glycemic variability, because they have been implicated in the cardiovascular complication. And fortunate part is that the fluctuation, the blood glucose is usually not reflected in HbA1c measurement. You have to have the conventional flash glucose monitoring. And recently, the time and range concept of diabetes management has been introduced, and doing the CGM and flash glucose monitoring, and that really has shown and just open our eyes that how glucose variability is there in inter-day variability and inter-day variability in the same individual who has got HbA1c of less than 7%. So the use of technology will definitely going to play a lot of role in near future to address some of this complexity in the management. Thank you so much.
Thank you, sir, for the extensive overview on what are the challenges and solutions of diabetes care in India. So, start with any questions, comments from the audience.
Thank you, sir. Thank you.
Thank you very much, sir.
I'll take just a minute. I think the basic problem is that when we as a physician or doctor think that our treatment alone is going to solve the problem, this concept has to be given up. You can't be pundit. You don't know what is diet. You don't know what is the carbohydrate content of different diet. You have to have a dedicated diabetes educator. And in this busy clinic where we have to see hundreds of patients per day, it is just not possible to justify. So as a physician, our role is only to give a diagnosis and write the treatment. You must have a dedicated diabetic educator who should be able to tell to the person how to take this medicine, what diet is important, how it should be monitored, and through the various either mobile contact or other contact, if you just give a ring, maybe 7 patients in a week, that gives a lot of confidence to the patient that after retirement about 5 years back, I am doing my center. And then I realized that how poorly we as a physician, device working in the institute for 35 to 40 years, are less knowledgeable as far as the various components of diet is concerned. Just a 5-second. I mean, the basic simple is when I say that, Dr. साहब में खाने में क्या खाना, तो सिंपल जो एडवाइस जो मरीज कहता है, आलू मत खाना और चीनी मत खाना और मिठाई मत खाना. No, your day should not be started with the cereals. That is one thing that you have to tell to the person. हमारा जो कॉन्सेप्ट है गली मोहल्ले में सुबह सुबह पूरी चाहिए, कचौड़ी चाहिए, पराठे चाहिए, and that gives the glycemic, the blood sugar of 300, 400. When I started asking the person that, look here, please don't take these items, at least you forget the gluten diet in the morning and take something else in the morning. There are so many items available. They don't used to, they are not listening. Then I told him, look here, you have got glucometer now. You take paratha one day, measure blood sugar after 1 hour. Second day, take kachori, measure 1 day. Third day, you just take the oatmeal and then measure blood glucose and then come to me. And then when they came back and they said, I never realized that after taking paratha and puri, the blood sugar will go to 300. But when I take the oatmeal, the blood sugar is hardly crossing more than 140 to 50. So unless until the concept of diabetic educator and their role is being implemented in diabetic management, I don't think we are going to achieve whatever the possible things which want to achieve, whether we talk about the time and range concept, the A1C or the glycemic variability. All these will be addressed most of the time by simple manipulation in the diet, in taking the confidence of the patient by a good diabetic educator. Thank you so much.
Thank you, sir. It's my privilege now to move on to the next talk, the current practices in GDM, who benefits. It's my honor to introduce Dr. C.S. Yajnik, sir. Dr. Yajnik is the director of the diabetes unit at the KEM Hospital and Research Center in Pune, India. He trained in Pune and in Oxford, UK, and investigates the high susceptibility of Indians to diabetes and related disorders. He's known for his description of the thin fat Indian and its intrauterine programming by maternal nutritional and metabolic factors. He's a current president of Sneha India and a trustee of the International DOHAD Society. Is an honorary visiting fellow MRC Life Codes Epidemiology Unit in Southampton in United Kingdom, and also a visiting professor at University of Exeter in UK and of the Danish Diabetes Academy. He received a Helmut Mannert Award of International Diabetes Federation in 2009, David Barker Medal of International DOHAD Society in 2011, and Outstanding Investigator Award of World India Diabetes Foundation. Last but not the least, Dr. Yajnik is advisor to many international organizations including Department of Biotechnology, ICMR, National Institute of Nutrition, India, World Health Organization, FIGO, and the Wellcome Trust, London, UK. Over to you, sir.
Thank you, sir. Thank you. And I'm going to speak a little bit sort of controversial about what has bothered me about the GDM concept. Hello, you'll need to change the slide. Here. About 12 years ago, I wrote this editorial in Diabetes Care, and that was on invitation from Fonseca. And the questions I raised that time was, is diabetes or GDM arises in pregnancy de novo? What is the life course trajectory of glucose in such a person? Because periconceptional period is the most important, and we diagnose GDM in the 3rd trimester. Is glucose the most important fuel, and do we need to consider others? Is insulin resistance a mechanism to maintain fetal growth, and do malnourished mothers have to be more insulin resistant? And finally, the crucial question, have our efforts to treat GDM reduced offspring diabetes both in the short and the long term? And over 12 years, I think we have some information on some of these questions. So the way we diagnose GDM is, if someone gets diagnosed with high glucose in pregnancy, we call it GDM. It's a very heterogeneous condition. So many other types of diabetes can also get called as GDM. And the two questions I'm going to try answer is, do we really know what is diabetes in pregnancy? And are we sure gestational diabetes is only gestational? So the first question, this is the famous HAPO study, sort of mother of all studies, and it showed a continuous monotonic increasing association between maternal fasting 1 hour and 2 hour glucose with the 4 outcomes they had. And these 4 outcomes were the weight of the baby, cesarean section rates, neonatal hypoglycemia, and cord blood C peptide. And as you can see, there is a continuous association, there is no threshold, there is no inflection point. So they were stumped with the idea that is there a diabetes in pregnancy, and they had to appoint then an expert group to define diabetes by manipulating the statistics. And then we accepted that a risk of more than 1.75 odds ratios above the median should be called diabetes. I mean, that was an entirely arbitrary decision. Are other fuels involved? This was only related to glucose. We had published this more than 10 years ago in our village cohort, and what we showed was glucose, both fasting and 2 hour, maternal cholesterol and maternal triglycerides were all strongly associated with different aspects of fetal growth, measured either as weight, length, skin folds, circumferences, whatever. So it's not only about glucose. And then there has been actually a very heated debate about the criteria for diagnosis. And I've just picked up one paper randomly written by Mukesh Kumar Agarwal, from Dubai. And in 2015, there were at least 10 different criteria being used in different parts of the world. Now there is even further addition of criteria. In other words, there is little agreement between a cut point for diagnosis so-called gestational diabetes. So in the first question, I am still struggling to understand what is diabetes in pregnancy. We have cut it at different points, but the outcomes which were driven from HAPO, which is the only outcome driven study, were continuous, monotonic, without any threshold. The second question is, now we call it gestational. So is it really gestational? And now there is of course a series of publications in last 15 years, because we decided to actually diagnose so-called gestational diabetes around 24 to 28 weeks under the philosophy that that is the time when the insulin resistance in the pregnancy starts increasing rapidly, and that is the time we can diagnose it. Once we decided that, then there was a competition to find out can we diagnose it earlier, and this summarizes a series of biochemical, molecular, ultrasound and other markers which have been shown to be abnormal even in the first trimester. In other words, whole lot of abnormalities are already there in the early trimester, but we diagnose them later, and now we say we should diagnose them early. A notable exception here is no one has really measured glucose, which is the relevant measure, and a whole lot of fancy molecular mechanisms have been suggested. All, to my own limited sort of knowledge, can be actually replaced by simple glucose measurement. Then fetal growth. We think that gestational diabetes promotes excessive growth, and that's what we should reduce in the third trimester. This is a beautiful paper on 10,000 pregnancies from Bradford in England, and where half of the pregnancies were South Asian and half were European, and you can see much earlier in the pregnancy, women who were diagnosed as GDM later in the pregnancy, their babies were growing abnormally. And additional point is South Asian babies were growing differently than the white babies. This has been a focus of my research for a long time, and I was very delighted that a large cohort with half South Asian and half European showed it that growth is abnormal right from the beginning. Then came this paper from Kaiser Permanente, which you know is an organization in California which has a very good electronic health record. So what they did was they found out women who were diagnosed with GDM, had they visited their facility for measurements in the earlier period many years ago, their concentration was on lipid abnormality, but I have highlighted the points that women who had gestational diabetes actually had abnormal glucose, BMI, higher family history and other parameters measured years before she became pregnant. In other words, her trajectory of abnormal metabolism and genetics was already there years before actually she even became pregnant. So this is of course the study which I have done for last 30 years, Pune maternal nutrition study, and that has provided some very interesting answers. We started the study in 1993 in what we call F0 generation. That means mothers who are married but not pregnant. We followed them through pregnancy, we followed their children, and now for last 4 years we are able to follow the children of the children. So this is the world's first birth cohort since David Barker's ideas, where we are able to follow F0, F1 and F2, 3 generations with a follow-up rate of more than 90%, most unique achievement. And I am going to tell you some interesting things here. This is a plot which shows in the F1 generation, that is the girls who were born between 1993 and 96, their serial measurements of glucose, insulin and other parameters from early age, which is 6 years of age, then 12 years, then 18 years, then in pregnancy, and in some girls even after pregnancy. So there are, you can see 5 different measurements on these girls over last 30 years. And what you can see is in the red are the girls who were diagnosed with high glucose in pregnancy, that is fasting glucose in the highest quartile, and blue are the girls in the lower 3 quartiles. What you can see is glucose was higher in these girls right from 6 years of age. So the girls whom we are today calling gestational hypoglycemia had higher glucose at 6, 12, 18 in pregnancy and continued to have it higher after delivery. In other words, they are tracking higher right from earlier age, and if we had probably measured their glucose even earlier than that, we would have probably found the same. And to cut the story short, it's a complex figure. What was their insulin abnormality that's seen in the last 2 panels is that their insulin secretion in relation to the prevalent insulin sensitivity, what we call disposition index, that means performance of beta cell against insulin resistance, was again abnormal right from 6 years, 12 years, 18 in pregnancy and 24 years. In other words, they had abnormal beta cell function right from early childhood. And unfortunately, we have concentrated on insulin resistance. I think there is a great need to think about it again. So short-term risks of GDM or diabetes in pregnancy, we know for babies are macrosomia and other problems. For mothers there are various things. What do we achieve by treating? In this now, the various GDM trials which are done, the 2 main ones are ACCOY, which was led from Australia, and Landon's trial, which was a multi-center trial run by NIH in US. And what it showed was that in mothers, there was a reduction in preeclampsia, There was a borderline reduction in cesarean delivery in the American trial, and induction of labor was increased in Acquai trial but not in Langdon. So in other words, mother benefited for preeclampsia and sometimes for reduced cesarean section. For child, there was a substantial reduction in fetal growth related parameters, that means macrosomia, and associated outcomes are reduced. And therefore, in a meta-analysis, they said GDM reduced the risk of selected important maternal outcomes like preeclampsia, macrosomia, LGA, cesarean, and shoulder dystocia. Remember, all these are related to big baby. And treatment could not reduce the risk of neonatal metabolic abnormalities or severe complications in the newborn. In the long run, mother has higher risk of becoming diabetic or getting cardiovascular disease, and baby has higher risk of getting obesity, diabetes, and brain problems. What were the issues? Now, some of you might have seen this brilliant paper published by Nikhil Tandon just last month. It is in JAMA, and it's his trial which he did in India, Bangladesh, on more than 1600 women which were diagnosed with GDM, and he tried to prevent permanent diabetes in them by intervening after delivery. And what are the conclusions? The question was, can an evidence-based lifestyle intervention adapted to local context prevent glycemic deterioration among women with recent GDM? And this study found that a lifestyle intervention was not effective in reducing glycemic deterioration, which occurred in a substantial proportion of women with recent GDM. So for the mother, in long run, even in a randomized control trial, we were not really able to reduce permanent diabetes. For baby, there are again two follow-up things. There was no reduction in either obesity or any of the metabolic abnormalities or cardiovascular risk factors for the baby, either in the Australian trial or in the American trial. Now, Indian scenario. Majority of our pregnancies are unplanned with no preconceptional glucose measurement. GDM is commonly diagnosed with figures between 10 to 25% using local criteria, predominantly based on DIPSI criteria, and obviously it is a big burden on the health system. Majority of diagnosed women receive intensive treatment, and the cost of GDM pregnancy is much higher than a non-GDM pregnancy. There is a substantial rural, urban, and socioeconomic inequity in the treatment, which you know better than I do. National birth weight in India is 2.8 kg, and in NFHS 4 and now NFHS 5, still 15 to 25% of babies are born low birth weight. And the rise in the birth weight in the offspring of diabetic mothers is approximately 100 grams. LGA figures in most of the studies are less than 10%, and interestingly, many of our GDM women still deliver what we call SGA babies, which is small for gestational age babies. That means the birth weight scenario in India is drastically different than the studies which we are using to base our policy on. Like in HAPO study, the average birth weight was 3.5 kg. 700 to 800 grams bigger than in India. And once you diagnose GDM, the medical thresholds for everything are reduced, because that woman says something, doctor immediately writes a prescription for some either investigation or medication. So investigations, induction, cesarean section, NICU admissions are considerably increased. And the treatment of GDM has not really reduced the long-term risk for the mother and the baby. A very few long-term follow-ups are done, and there is no RCT of GDM treatment in India. We followed up 200 babies born in diabetic pregnancies in my department at an average age of 15 years. these mothers were intensively treated, because I am quite obsessive about treating diabetes in pregnancy, and this data has been collected over 30 years. What we found was babies born to diabetic mothers had 5% incidence of diabetes and 37% incidence of pre-diabetes by 15 years of age, compared to 20% pre-diabetes in the babies born to non-diabetic mothers. In other words, whatever thing we did to the mother after diagnosis of GDM seems to have done very little for baby's outcome for diabetes. I'm going to tell you an interesting story, because I come from the world of DOHAD, which is Developmental Origins of Health and Disease, and where we say periconceptional epigenetic programming determines your risk of future non-communicable disease. And that starts with ova, sperm, the embryo, and the placental development. And the so-called epigenetic reprogramming of the baby happens within first 48 hours after conception. So a very noted embryologist from UK said, for a given person, it's not birth, marriage or death, but gastrulation is the most important time in your life, because that is the time when the 3 layers, germ layers, are let down epigenetically. And that happens within 48 to 72 hours of conception. And we also have this interesting idea coming from Andrew Hattersley in Exeter about fetal insulin, that Western world is talking of overweight mothers with gestational diabetes which produce bigger babies. In India, the major problem has been the so-called thrifty phenotype because of maternal undernutrition, both micro and macronutrient. So in a way, what Huxley said now is becoming, we think, medical science has made such tremendous progress that there is hardly a healthy human left. So we are diagnosing, overdiagnosing various conditions without looking at the outcomes of what we are doing. So my random thoughts are that pregnancy glycemia in an undernourished population like ours, where more than 50% of the mothers still have a BMI less than 20. Nutritional supply is obviously a mechanism to promote fetal growth. I mean, obvious. Is higher glycemia nature's way to improve fetal growth? Very likely yes, but on the current background, when things have rapidly changed, we are seeing the side effects of this also. When and how it may go wrong, we really don't know. The elephant in the room may be insulin resistance, and we have done massive work by collecting data over 13,000 pregnancies from across the world to show that Indian women have the lowest insulin resistance in the world. So again, there is a food for thought, and that I will discuss sometime later, because it's a very elaborate finding. And I think run Milkha run, so I am saying think Milkha think. And there are of course elephants in the room, and probably you have heard of a book called Elephant in the Womb. And I think that elephant in the womb might be insulin resistance mechanisms which may be different in Indians. So finally I am going to summarize that there is a lot to learn yet. Sensitive to local situations, these definitions which we are moving across the world are needed to be sensitized to individual. That's part of personalized medicine, and that needs to be outcome based, not someone's thinking. Therefore, we need national database and registry, we need ethical interventions, and we need personalized guidelines. Diagnosing so-called gestational diabetes in pregnancy is too late, and what we are diagnosing in third trimester is actually so late that all we can do is reduce the size of the baby, because that's when the body size is built up. Preconceptional detection and correction is probably the way to go, and therefore it goes from clinic to the community, and therefore it's not really the doctors, but it's the public health system which really needs to drive this program, so that we can catch them before the periconceptional programming has occurred. Otherwise, we will continue to see an exaggerated epidemic in young people who are born in what we are calling gestational diabetes. Thank you.
Thank you, Dr. Yajnik. We'll take a quick couple questions before we move on to the last.
At all. And the other thing I would like you to kindly elaborate to me is about the preconceptional detection and correction. Because we are talking about GDMs, that means we are talking about raised blood glucose, whatever blood glucose it is after 20 weeks. So most of them preconceptually are supposed to have a normal blood glucose. So how do we handle that situation? How do we detect, and how do you really want to prevent a GDM in these patients? And finally, what is your, again, a message for management of GDM in the years to come? Because Professor Seshaya is here, the authority. Yesterday he was talking about primordial prevention of diabetes, where you try to find out the maternal blood glucose before the 10 weeks, and even the slighter raise could lead to the infant being diabetic in the future. Thank you.
Yeah, so basically I am objecting to the term gestational diabetes. And I think first time in the world, in the Pune maternal nutrition study, we are able to show that what we diagnose in pregnancy has been abnormal throughout the life cycle. The important recognition is that the periconceptional programming of future non-communicable disease in the baby happens periconceptionally. And at time woman doesn't even know she is pregnant, she has never seen a doctor. And therefore only way to approach that is preconceptionally. And therefore I am saying that it's not doctors, but it's the public health system which needs to take this up. I don't know whether you are aware of the CNNS report which was published in 2017. It's the comprehensive national nutrition survey done across all the states. And it showed that in children between 5 to 10 years and in adolescents between 11 to 20 years, across India, prevalence of pre-diabetes is very high. Like it is in our cohort, 30% of these people at BMI 19 in PMNS had pre-diabetes at 18 years of age. In other words, we really need to rethink. And otherwise we will continue to pay lip service to the gestational diabetes idea. And I showed we really don't know what is diabetes in pregnancy. So there is a need for basic rethinking, and there is no point me saying that we should treat gestational diabetes like this or that, because I am just challenging that idea. But given the current standards of practice, as a doctor I have to follow certain instructions, and there is a national guideline, etc. We are following it, but I think it's time to think what are the outcomes of our actions. And
sir, a quick comment from you, a question, and we need to close the session.
No, lifestyle is beneficial, and lifestyle of very young needs to be improved right from very early age. So that is the crux of the matter.
I will have 2 brief comments.
Yeah. Thank you.
Brilliant presentation, Yajnik, as ever. 2 quick comments. One thing is, we have worked and we have published also 1.5 decades ago. There is a continuum, as we have correctly said, in non-diabetic pregnant women. We have measured insulin resistance vis-a-vis the growth of the fetus, the femoral length, the parietal diameter, and in utero and the abdominal circumference. With per degree rise of insulin resistance of human, there is a linear correlation with this. So, as he correctly said. But Coming to IGT, GDM, what Professor Sheshe and all of us have been telling, it is IGT of pregnancy when the maternal insulin secretion fails to maintain the blood glucose level, and that is the cutoff point, we call it IGT. Second comment I would like to mention, that in the second trimester of pregnancy, it becomes lipogenic. Why? Because lipid dependent, because glucose is taken by the fetus, and the maternal metabolism shifts from glucose-centric to lipid-centric. So naturally you have hyperlipidemia in the mother, which should not be treated with pharmacological agents, only nutritional agents, nutritional modification. And those women...
So we are running short of time, sir, please.
Just a moment. Those women who after delivery continue to have dyslipidemia, they in the long run develop macrovascular disease.
Thank you very much. Thank you, sir.
Right. I mean, this slide shows...
Can I have one question, please, sir?
No,
Yes.
please. Sir, we have to take the next question. We can have an individual discussion. We need to move on. The individuals who need to take the... So we have the other speakers waiting, sir. We can take this discussion individually, sir.
Sir, you say that instead of good management of GDM, we cannot check out the later complications, just like obesity in childhood, the later complications. So what is the probable explanation for this?
What is the
What are
explanation?
the probable explanations? Because we cannot check the complications in spite of the good treatment.
Because we are treating after the complication has been established by periconceptional epigenetics.
Okay,
And we are then, I have many slides on this, but there is
Certainly,
a
sir.
saying in English, to bolt the horse, to close the door after the horse is bolted. So the horse is already bolted,
Sir.
but
Please
we are
accept our
struggling.
apologies. We can have some offline
Thank you.
sessions one-to-one, and we'll move on to the, because of the paucity of time, move on to the third talk for today.
So to quickly introduce our next speaker, we have with us Dr. Siddharth Das. So is an MD, FRCP from Glasgow, Edinburgh and London. He's a senior consultant in medicine and diabetes. He's been the founder fellow of International College of Clinical Nutrition, RSSDI and Diabetes India. Sir is a fellow of Indian College of Physicians, Uttar Pradesh Diabetes Foundation. He's been the president of RSSDI 2002 and 2003. Sir has been the president of the scientific section of Diabetes Association of India 2002 and 3. He's been the chairman of the scientific committee, Association of Physicians of India 2003. Sir has been a patron in the RSSDI Orissa chapter, past chairman, API Orissa branch, and past chairman of RSSDI Orissa chapter. He has more than 150 publications in peer-reviewed national and international journals, 48 chapters in textbooks and monographs, recipients of 20 national orations and awards, 160 guest updated lectures delivered in more than 51 places. He has been honored with MRDF Lifetime Contribution Award, Lifetime Achievement Award 2019 Diabetes India, Distinguished Service Awards 2019 RSSDI, and Sir has been the chairman of Ethics Committee Utkal University Bhubaneswar, and he's also a medical expert to Honorary Orissa Human Rights Commission 2010 to 19, and Sir will take us through his talk, Proteinuric to Non-Proteinuric Nephropathy in Diabetes, a Paradigm Shift. Over to you, sir.
Thank you very much for the kind introduction. I'm honored that Professor Shesha is in the audience. President RSSDA is also in the audience. Well, coming to the topic, the proteinuric to non-proteinuric nephropathy in diabetes mellitus, the paradigm shift. When you think of diabetic nephropathy, we first think of microalbuminuria, then albuminuria, but the situation has changed of late. Now, diabetes is a pervasive cause of end-stage kidney disease in the Western population and a major contributor to CKD epidemic worldwide. 20 to 30% of type 2 diabetics in the Western world have nephropathy, and 44% in USA and 30% in Europe diabetics have been found to have diabetic nephropathy. Well, a reduced GFR is more common among diabetic patients than in non-diabetic subjects in general, but also reveal that a large number of such patients will never show levels of proteinuria above the traditional definition of overt diabetic nephropathy, that is more than 500 milligram per gram in the urine. That means albuminuria is no more sine qua non of diabetic nephropathy. Now, the early looking at the Indian scenario, early work was done way back in 1975 to 78 at the aegis of WHO, and where creatinine levels more than 1.5 milligram and to 24 hours urinary excretion for more than 500 milligram per 100 liter of urine was thought to be a diabetic nephropathy. And in this multinational study, when you take the duration of diabetes from 0 to 6 years, then 6 to 13 years, and then more than 14 years, the prevalence of nephropathy increased from 9.3% in the males to about 23% in the males, and from 4.2% in the females to 13.6% females, suggesting that duration of diabetes is definitely a big contributor for developing diabetic nephropathy. Now, my institution where I was a student, I was a faculty, I was the dean principal also, retired in 2019, was also part of the WHO study. And what was the finding? That the finding was 12.2% of males and 5.3% females had diabetes, had nephropathy, and as the duration increased, similarly 22.5% of males and 7.5% females had diabetic nephropathy. The interesting finding came from the chronic kidney disease registry by the Indian Society of Nephrology, and they found that diabetes mellitus is the cause of CKD in 31.2% of patients from all causes leading to chronic kidney disease. Now, looking at a paper which we published a few years ago, 41 patients had, it is a morbidity profile and causes of mortality in type 2 diabetics hospitalized in our hospital. We found that 56% of the patients who were hospitalized with type 2 diabetes had nephropathy. And while only duration of diabetes was strongly associated with nephropathy and neuropathy, the cardiovascular related deaths were most common cause of, to be followed by infection and chronic kidney disease. Even the hospitalized patient, we find that the chronic kidney disease is a big burden for the cause of mortality. Now, this is a very interesting book published way back by none other than Carl Erik Mogensen, The Kidney and Hypertension and Diabetes Mellitus. All of us know, next to Bright's disease, anybody who defined kidney disease, staging of the renal pathology was Mogensen. And in his classification, if you look at the, then it was called IDDM. If you look at the IDDM table in his book, if you look at hyperinfiltration, microalbuminuria, and clinical proteinuria, they had strong predictive value, but the structural reasons were still unknown, how and why this happened. If you look at his own publication on type 2 diabetes or in NIDDM, he mentioned very clearly, it has hence become clear that the course of complications and the implications of microalbuminuria differ in several respects within the two types of diabetes. So they are not the same disease. Microalbuminuria in type 2 diabetes does not necessarily mean is a progressive diabetic nephropathy. Now, looking at diabetic nephron and alter hemodynamics, if you look, there is at the afferent vasodilation. Why does there is afferent artery vasodilation? There is hyperglycemia, high blood amino acid levels, and low sodium chloride delivery to the macula densa, and so there is dilatation of the afferent vessel of the glomeruli in a diabetic. Now, as you go down in the descending loop of Henle, there is increased sodium chloride reabsorption and glucose reabsorption. Sodium chloride is secondary to glucose reabsorption. As you go up in the ascending loop of Henle, decreased distal delivery of sodium chloride, and then ultimately in the afferent, what happens is a vasoconstriction because of decreased feedback. And so what happens, this peculiarity occurs, the afferent arteriole is dilated, the efferent arteriole from the glomerulus is constricted. Now, in epidemiological study comprising secular trends in prevalence of diabetic kidney disease in USA across 3 time windows, 88, 94, 99 to 2004 and 2005-2008, they found that there is an increase over time from 2.2% to 3.3% in the prevalence of nephropathy defined by albuminuria. The overall CKD increases from 14.9 to 17%, whereas albuminuria trends to decrease. I beg your attention to this finding of this long-term study from USA. The observations, the same database extent of 2014 substantially confirmed that the prevalence of albuminuria decreased progressively over time from 20.8% to 15.9%. In contrast, the prevalence of reduced eGFR increased from 9.2% to 14.1% with a similar pattern of reduced eGFR. So there was a discordance between reduction in GFR and albuminuria. We are all aware of this study as diabetologists that tight glycemic control definitely helps in reducing proteinuria and microalbuminuria.
And you can see, we know about the DCCT, the DCCT headache, the UKPDs, the advanced and accord, all show that we decrease in HbA1c levels, there was a finite reduction in albuminuria and macroalbuminuria. Now coming to Indian scenario, I always have a habit of showing Indian scenario. From the QURE study, from the QURE study, overt proteinuria was found only in 2.2%, whereas microalbuminuria is found in 26.9%. So a variety of causes can contribute to microalbuminuria. The Chinam-Pedrural study or CRDPP study again showed diabetic nephropathy in 24.3%. Study from the Canyer and North Delhi clinic-based studies showed about 26.8 to 15.3% of patients having diabetic nephropathy. The Cindy study, which was done by Diabetes India itself, we found that newly detected diabetes nephropathy was found in 13.15% of patients. Now, microalbuminuria in Indians subject to type 1 and type 2 diabetes. If you look at the Mumbai study, type 1 diabetics, microalbuminuria is a marker of progression of diabetic nephropathy. This was published in JAPI way back in 1999. If you look at this study, in type 2 diabetics, it is a marker of generalized vascular endothelial dysfunction. So this is the big difference here, that microalbuminuria does not mean nephropathy in type 2 diabetes alone. Now coming to our own study, with the improvement of proteinuria consequent to tight blood glucose control, you can see at entry after 1 year, after 2 years, the urinary albumin levels reduced from 280 to 890 and 190 to 80 milligram per deciliter. Now coming to the proteinuria to non-proteinuria paradigm shift, historical trends showing improvements in glycemic control over the time and a large database and a widespread use of antagonists to the renin-angiotensin system, which definitely take care of the constriction of the efferent vessel in the glomeruli, may have contributed to the decrease in the prevalence of glomerular lesions. I beg your kind attention to this particular word. Decrease in the prevalence of glomerular lesions, and allowed the emergence of other types of renal lesions affecting the interstitium and vasculature, cause of progressive renal damage without triggering proteinuria or producing just mild to moderate increase in the levels of this biomarker. So, the vast use of ARBs and AC inhibitors and tight glycemic control, whether by lifestyle modification or pharmacotherapy, has definitely contributed in reducing microalbuminuria. The paradigm that proteinuria is a necessary step in the course of chronic kidney disease associated with type 2 diabetes causing renal dysfunction and progression to end-stage kidney disease has been reframed. Microalbuminuria in type 2 diabetic patient found to be a marker of generalized vascular endothelial dysfunction. Agarwal at the study is published in JAPI, is professor head of nephrology at AIIMS New Delhi. 17.5% newly diagnosed diabetics with microalbuminuria had hypertension. They had no diabetes, they had hypertension. Now looking at the two different phenotypes of proteinuria, macro and albuminuria and GFR decline. So this is the GFR decline, this is GFR decline. This is classical phenotype, is albuminuria. This is microalbuminuria, and this is macroproteinuria, gross proteinuria. You can look that the decline GFR is more rapid in the normal albumuric patients rather than the frank proteinuric patients. This is the paradigm shift. Now, International Diabetes Federation and the International Society for Nephrology, including 30,000 type 2 diabetic patients from 33 countries, found that the overall prevalence of normal albuminuria, microalbuminuria and macroalbuminuria was 51%, 39%, 10% respectively, with wide racial differences. So racial difference also contributes to the, as what Dr. Yagnik said in the previous talk, that they like preconceptional. So we know should know about the ethnicity of the person, his background, his genetic background, which helps us definitely to decide on his disease and management. In the absence of proteinuria, a reduced GFR is observed in about 1 diabetic patients out of 5, 20% of 25%. A risk not dramatically different from the resistant patient with microalbuminuria. Proteinuria cannot be considered as a marker of diabetic nephropathy tout coat. Rather, proteinuria in diabetics has to be seen as an indicator of glomerular lesion in diabetic patient CKD. So, microalbuminuria or albuminuria defines glomerular disease. Proteinuria is a distinguishing feature of a primary or secondary form of chronic glomerulitis. The contribution of proteinuric nephropathy to the global ESKD burden is still poorly focused. In type 2 diabetics, non-proteinuric DKD is more frequent than proteinuric DKD. The substantial research effort is still needed to develop treatment strategies that may help the vast majority of CKD patients who eventually develop end-stage kidney disease via mechanisms pathways other than proteinuria. Now, the risk factors that might trigger a progressive decline in the glomerular filtration rate in the absence of proteinuria, albuminuria include hypertension, obesity, high serum triglycerides, and glomerular hyperfiltration and alteration that is not confined to diabetes mellitus, being commonly seen also in early stage of hypertension. So, hypertension contributes in two ways. Now, if you look at this cartoon, hypertension leads to tubular interstitial inflammation. Obesity, overweight lead to alteration in the adipokines and secondary pro-inflammatory changes. Obesity per se is a pro-inflammatory situation. High serum triglycerides enhance insulin resistance by lipotoxicity and again lead to pro-inflammatory state, and glomerular hyperfiltration at single nephron level in individuals with low nephron mass can contribute to this. Now, we looked at studies of markers of atherosclerosis including insulin resistance in patients with chronic renal failure, published way back in 2012. So, what we found that comparison of various parameters between the three groups, that is non-diabetic CKD, diabetic CKD and healthy controls, revealed that insulin resistance, beta cell dysfunction, dyslipidemia, C-reactive protein, uric acid and carotid intima thickness were significantly higher among CKD patients than controls. Further, greater degree of insulin resistance and beta cell dysfunction in diabetic kidney disease than non-diabetics. So, these are nothing to do with macroalbuminuria or glomerulitis. Now, what happens in diabetic kidney disease? Resorption of albumin escaped from the glomerular filter by the tubulin megalin complex in renal tubular cells, sets into motion an nephrotoxic pathway, activates the ROS synthesis, enhances the synthesis of nuclear factor kappa B controlled cytokine cascade, upregulates endothelin 1, transforming growth factor beta, beta, TGF beta, and ultimately leading to tubular intestinal atrophy and fibrosis. The cartoon again same thing. If you look at the tubulin albumin megalin complex, RNAs are produced, ROS enhanced, endothelin, monocyte chemotactic protein, TGF beta, and nuclear factor kappa B pro-inflammatory cytokines are enhanced. Now, looking at biomarker associated with predicting DKD or diabetic kidney disease, if you look at the albumin, macroalbumin, and microalbumin, they are the markers of glomerular disease. If you look at the markers of inflammation and endothelial damage, starting with alpha-1 antitrypsin to VGA, to TNF alpha, to endostatin, then to look at the inflammation, the proximal tubule, again KIM1, loop of Henle, osteopontin, uromodulin, Tam-Horsfall protein, a collecting duct, copeptin, and distal tubule osteopontin. So, instead of focusing only on macroalbuminuria, the focus now shift to all these biomarkers of chronic kidney disease in diabetics. So, summarizing that again, just which I have told you, this is proximal tubule are these protein biomarkers, loop of Henle, osteopontin, uromodulin, distal tubule osteopontin, NGL, and copeptin. So, what we did, we went one step ahead. We looked at the association of nuclear factor kappa B1 gene polymorphism with inflammatory markers in patients with type 2 diabetes with or without renal involvement in our part of the research published, I think, in 2020. If you look at the healthy controls, type 2 diabetics without nephropathy, type 2 diabetics with nephropathy, if you like the urine albumin creatine ratio, urine monocyte chemotactic protein and TNF alpha, all were higher in diabetic nephropathy, all were higher compared to the healthy controls and definitely compared to the type 2 diabetic without nephropathy. If you look at the nuclear factor kappa B gene polymorphism, if we look at the healthy controls, the highest polymorphism was in deletion and deletion, whereas in case of those diabetic nephropathy was insertion. So, this is genetically primed. Why the inflammation is more in diabetic and less in a non-diabetic is genetically primed. Now, time has come, we should analyze the genetic basis of diabetic nephropathy, not being satisfied with microalbuminuria. The appeal of the paradigm shift in understanding diabetic kidney disease. Accumulating data suggests that the proportion of CKD patients without proteinuria are substantial. In a survey made by the framework of the third National Health and Nutrition Examination Survey NEHANS 3, as many as 37% of patients with GFR less than 30 had no albuminuria. Among patients with type 2 diabetes with GRF less than 60 ml per minute, 1.73 meters square per second, was normal albuminuric. Glomerulitis are most often proteinuric disease, and all diabetic nephropathy are no more pathology in the glomerulus because of the rampant use of ARBs and ACE inhibitors. The incidence of ESKD due to glomerulitis plateaued in 1999 and since then has declined steadily. Markers of interstitial involvement leading to non-proteinuric DKD has to be evaluated at an early stage. More exhaustive genetic study in different population groups will guide the future management of diabetic nephropathy. This is a very important slide for me and which I'll cherish throughout the life. On 2019, we were three of us, almost 2 decades younger to Professor Sheshe and Dr. Munichudappa. We three were honored with lifetime contribution award from Diabetes India, and Sadikot was there to present this to us. Thank you very much.
I thank all the honorable speakers for today's session. Because of the paucity of time, we conclude here, and we can request the next chairpersons to take over for the next session.